Dear great surgeons, I've missed you all a lot. Hope you are all safe, and let's have a journey through our head and neck anatomy. Hope it's being more lovely and more productive together. Together we can with the grace of God. So let's sum up some important embryological applied anatomy for head and neck surgery. There are 5 pairs of pharyngeal arches. They are numbered from 1 to 6. But take care, the 5th branchial arch, the 5th pharyngeal arch is rudimentary. There is no 5th branchial arch in our anatomy. It's rudimentary. And by the way, the trigeminal nerve from the 1st branchial arch and the facial nerve from the 2nd branchial arch, while the cricothyroid muscle is from the 4th branchial arch, while the intrinsic laryngeal muscle is from the 6th branchial arch. And just like the trigeminal nerve, we have the anterior digastric muscle from the 1st branchial arch. I know that the branchial arches can confuse you a little bit. It's a pure memorization question. So let's have a slight simple mnemonic to remember at least some of the structure present in the arches. We have the arches from 1 to 6, but take care, the 5th is rudimentary. So when we call 6, remember that the 6th is the 5th one in your order, not the 5th branchial arch, because the 5th is rudimentary, but we are talking about the 6th branchial arch. So it's a 5, 7, 9, 10, 10. Again, 5, 7, 9, 10, 10. The first branchial arch will be composing the trigeminal nerve number 5 with its mandibular branch, and the second branchial arch will be forming the facial nerve, nerve number 7, and the third branchial arch will be forming the glossopharyngeal, which is nerve number 9, and the fourth branchial arch will be forming the vagus with the pharyngeal branch, while the vagus recurrent laryngeal branch in the 6th branchial arch. This is regarding to the nerves. While regarding the branchial arches bone structure, remember that the cartilage of the quadrate and the Michels in the first branchial arch, while the rectors in the second, and the hyoid bone in the second branchial arch. And this is important. The next trick we have talked about before is the belly of the digastric. We have anterior belly of digastric and posterior belly of digastric. This is a frequent trick in the exam because the anterior belly of the digastric in the first branchial arch, while the posterior belly of the digastric in the second. So the anterior is the first and the posterior will be the second regarding the digastric muscle. A very famous question asking you about the surface anatomy and the direct relation to the mandible. What structure could be directly related to the mandible? It's the lingual nerve. The lingual nerve descends just anterior to the inferior alveolar nerve near the mandibular foramen, and it passes forward between the mandible and the medial trigoid. It is then in direct contact with the mandible in a shallow groove below the medial border of the third molar. It then crosses the submandibular duct to run to the tongue. The facial artery appears at the inferior border of the mandible, by the way, and grooves the mandible as it hooks around the inferior border. Isn't it funny that the 5th cranial nerve is the trigeminal nerve and make it confusing? It has been confusing me since pre-graduation that the 5th cranial nerve is the same as the trigeminal. However, it had 3 branches, the ophthalmic, maxillary, and the mandibular. And let's track a little bit the mandibular because it's a little bit important in our exam and the many records regarding the mandibular branch, because the mandibular branch will give us the inferior alveolar nerve, and the inferior alveolar will give us the mental nerve, which is a branch of the inferior alveolar and exits via the mental foramen and divides into 3 branches below the depressor anguli oris muscle. One branch supplies the skin of the shin, and the other 2 innervate the skin and mucous membrane of the lower lip. So the mental nerve of the inferior alveolar, if got injured, they won't feel the sensation of the kiss. So it's important a little bit. You are such amazing surgeons. Yes, the external carotid gives the thyroid, superior thyroid, artery as its first branch, while the internal carotid in the neck has no branches. And by the way, it's very important in clinical applied information. It's not just a logic, because intraoperatively, if you want to differentiate between the external carotid and the internal carotid in the neck, it's differentiated by its anatomical side as well as the branching, because the internal carotid has no branches in the neck, while the external carotid will have branches, and you will recognize the first branch going to the thyroid, superior thyroid. And of course, the inferior thyroid will be coming from the thyrocervical trunk. Keep it in mind. Another trick regarding the internal carotid artery enters the cranial cavity through the carotid canal in the petrous part of the temporal bone. It doesn't groove the sphenoid bone, by the way. The internal carotid artery is a terminal branch of the common carotid artery, because we all agree that the artery from proximal to distal. Proximally we have the heart, and distally all the body. So the internal carotid is terminated as is a terminal branch from the common carotid artery. Common carotid ending as internal and external carotid. The internal carotid artery gives no branches in the neck. Again, no branches from internal carotid in the neck. It's important clinical applied, as we agreed on. You can differentiate between the internal carotid and the external carotid in the neck. When you don't find any branching coming out of the artery, this is the internal carotid artery. Take care, the Thyroglossal muscle and the stylopharyngeus muscle and the cranial nerve number 9, the glossopharyngeal, and the pharyngeal arch branch of the vagus. So they pass between the external and the internal carotid artery. Again, the styloglossal muscle and the stylopharyngeal muscle, as well as glossopharyngeal nerve and the pharyngeal branch of the vagus, pass between the external and internal carotid. And this is a pure memorization, yet it's pretty asked in the exam. Why? Because it might be compressed and by the carotid body tumor, or can be liable to injury during endarterectomy. So keep it in mind. The internal carotid artery, accompanied by its sympathetic plexus, and coursed through the cavernous sinus and is crossed by the abducent nerve. We all remember the cavernous sinus, and it's important, and from the very important structure passing within the cavernous sinus is the internal carotid artery, not the external. Take care. Let's revise together a very common question in the exam, which is about the foramina of the skull. One of them will be asked in the exam. For example, the foramen ovale is a part of the greater wing of the sphenoid and transmits the mandibular and the lesser petrosal nerve. The chorda tympani enters the infratemporal fossa, and the chorda tympani is a branch from the facial nerve, by the way, through the pterygotympanic fissure and run downward forward to join the lingual nerve. The foramen spinosum transmits the middle meningeal artery from the infratemporal fossa into the cranial cavity. Again, the foramen spinosum transmits the middle meningeal artery from the infratemporal fossa into the cranial cavity. And it's very important, the middle meningeal artery. The jugular foramen transmits the following structure from below backward: inferior petrosal sinus, cranial nerve number 9, 10, 11, and the large sigmoid sinus. Again, the jugular foramen transmit from before backward, inferior petrosal sinus, cranial nerve number 9, 10, and 11, as well as the large sigmoid sinus, while the facial nerve exits the cranium by the stylomastoid foramen. So take care, the chorda tympani is a branch from the facial nerve. Yes, it joins the lingual nerve, which is a branch from the trigeminal nerve, but the chorda tympani, facial, the lingual nerve, trigeminal. Don't confuse them, because they are joining the journey together towards the tongue. So this brings up to the innervation of the tongue. So the innervation of the tongue. All the intrinsic and extrinsic muscles are supplied by the hypoglossal nerve, except the palatoglossal is supplied by pharyngeal plexus via the vagus nerve. This is the motor sensation of the tongue. While the sensory sensation, the sensory innervation, we have to divide the tongue into three portions: the anterior two-thirds and the posterior third, as well as the root of the tongue. The anterior two-third, the general sensation by the lingual nerve, which is a branch from the trigeminal, while the taste sensation, excluding the velar pollier, by the chorda tympani. So the general sensation by the lingual nerve and the taste sensation by the chorda tympani. And remember, the lingual via the trigeminal and the chorda tympani is the facial. While the posterior third, general and taste sensation by the glossopharyngeal nerve number 9. Again, the posterior third via the general and taste sensation both by the glossopharyngeal, while anteriorly you have both the fifth and seventh, while posteriorly we have only the glossopharyngeal, while the root of the tongue via internal laryngeal branch of the vagus. Another famous applied anatomy is regarding cervical rib. In 1% of the individuals, the costal element of the seventh cervical vertebra from projection called cervical rib. They are usually cartilaginous but may be partially or totally calcified. And here we have a clinically applied information. Commonly, they have a head, neck, and tubercle which vary amount of body. They extend into the posterior triangle of the neck, where they may be freely anteriorly or attached to the first rib or even the sternum. So, usually these ribs cause no symptoms and are diagnosed after incidental finding of chest X-ray. So, why, Bishoy, you are trying to confuse us with the cervical rib? Wait, take care. In some cases, the subclavian artery and the lower trunk of the brachial plexus are kinked, where they pass over the cervical rib. Compression of this structure between this extra rib and the anterior scalene muscle may produce symptoms of nerve and arterial compression, producing the neurovascular compression syndrome. Often, tingling and numbness, impaired circulation to the upper limb don't appear until the age of puberty, when the neck elongates and the shoulders tend to droop slightly. So again, it might be passing silent or might be manifested, or even can be incidental finding, but keep it in mind. This is the importance of the cervical rib. And by the way, it can cause the thoracic outlet syndrome. It can be one of the factors confusing and causing the thoracic outlet syndrome, and even the steel phenomena. Does anyone know what is the steel phenomena? The subclavian steel syndrome or phenomena is a reduced quantity of blood flow through the proximal subclavian artery. As a result, the blood travels up one of the other blood vessels to the brain and reaches the basilar artery or goes around the cerebral artery circulation and descend via the contralateral vertebral artery to the subclavian with the proximal blockage and feeds blood to the distal subclavian artery, where we all know and we all agree that the arteries are from proximal to distal, but here the contralateral side will be having the blood supply from distal to proximal. The cricoid cartilage is very important. The cricoid cartilage is C6, and in adult, the narrowest part of the airway is at the level of the vocal cord, and in children, it's at the level of the cricoid cartilage. The upper border of the cricoid cartilage is attached to the thyroid cartilage, not hyoid bone. Again, the upper border of the cricoid cartilage is attached to the thyroid cartilage, and the lower border is attached to the first tracheal ring. And when we are talking about the cricoid cartilage vertebral level, we are talking about C6. The application of the cricoid pressure to control regurgitation or reduce the risk of aspiration of gastric content during the introduction of anesthesia was described by Dr. Selleck in 1961. It doesn't matter this information, but we have to know that it doesn't prevent aspiration into the trachea, and it can't prevent regurgitation up to the esophagus. To provide protection in the most of the adult population, a force of 44 Newton should be applied to the cricoid cartilage, not only 4 Newton. You want to be asked regarding this question in the exam. All you need to know about the cricoid cartilage: it is a narrowest part of the airway at the level of the vocal cord, while in children in the level of the cricoid cartilage. And not confuse them. And the upper part of the cricoid cartilage is attached to the thyroid cartilage, not the hyoid bone. The thyroid cartilage is not the same as the hyoid bone. That's why we gave them different names. And the lower border is attached to the first tracheal ring. Take care. And if we mention that the level of the cricoid cartilage is at C6, we have to mention that the level of the hyoid bone is at C3. Those are very important vertebral level. So let's remember some important cervical vertebra levels. C1, open the mouth, then spinal root of the spinal accessory nerve, cross transverse process of the atlas, and C2 is superior cervical ganglion, while C3 is the body of the hyoid, and C4 is the upper thyroid cartilage, bifurcation of the common carotid artery, while C6 is the cricoid cartilage. C7 first easily palpate spinous process till late ganglion. Take care. If you are not an ENT or otolaryngologist, so the larynx and the whole vocal cord thing is a little bit confusing. So let's crack them together. Regarding the intrinsic muscle of the larynx, to abduct the cord, use the posterior cricoarytenoid, and to adduct the cord, use the lateral and interarytenoid. So abduction by the cricoarytenoid, while the adduction using the lateral cricoarytenoid and the interarytenoid. And the sphincter to this vestibule are the aryepiglottic and thyroepiglottic. Again, the sphincter or the vestibule are the aryepiglottic and thyroepiglottic. The vocal cord tension is regulated by the cricoarytenoid, those are the tensors, and the thyroarytenoid, those are the relaxers, and the vocales, those are for the fine adjustment. From the vocales, this is an orchestra in your larynx. All the intrinsic muscle of the larynx are supplied by the recurrent laryngeal nerve. Take care, except the cricoarytenoid. No, the cricothyroid. We all agree that the cricoarytenoid is the abduction of the cord. All the intrinsic muscles are supplied by the recurrent laryngeal nerve. What are the intrinsic muscles? The posterior cricoarytenoid and the lateral cricoarytenoid, as well as the interarytenoid, while the cricothyroid is by the external branch of the superior laryngeal nerve, not internal branch. The remaglotidis is the space between the two vocal cord. Again, the remaglotidis is the space between the two true vocal cords. The ventricle of the larynx is the fossa between the true and false cords, and the part between the inlet of the false cord is the vestibule. Listen to this again from time to time. If you get a question in the exam, it will be one question, so don't exhaust yourself with this information. Just listen it during drinking your favorite drink, and you will get it when you need it in the exam. From this whole thing regarding the larynx, take care that the cricoarytenoid abducts the cord, while the cricothyroid is supplied by the external branch of the superior laryngeal nerve. So take this wisdom from the larynx. We might be apparently different in action, different in the rules, different in the appearance, but we all have same origin. We are having all the same core for the better good, just like the recurrent laryngeal nerve, which supply all the intrinsic muscle. And when we have only one different cricothyroid muscle, which is supplied by the external branch of the superior laryngeal nerve, this doesn't mean we are enemies. We are all here to do one thing, is to function the larynx. And we have even a vocalese for fine adjustment of the larynx to give us a whole orchestra inside our larynx, inside our voice, to can talk and present in different ways. So being different sometimes is a completion. And we have a surprisingly coincidence that the recurrent laryngeal nerve and superior laryngeal nerve are branches from the vagus nerve. Different actions from different muscle, different tracks, but they have a common origin for a better good. Together we can. Dearest great surgeons, let's pay attention to the blood supply and the arterial supply of the brain. The arterial supply to the brain is provided by two internal carotid arteries. They are terminal branches from the common carotid arteries. 2/3 of the blood supply are from the internal carotid artery, and the two vertebral arteries 1/3 of the blood supply. So again, the blood supply of the brain 2/3 from the carotid artery and 1/3 from the vertebral artery. The internal carotid artery divides into anterior and middle cerebral arteries. Again, internal carotid artery divides into anterior and middle cerebral, which supply the anterior 2/3 of the cerebral hemispheres. The ophthalmic artery is a branch of the internal carotid artery, by the way, not anterior cerebral artery. Take care, the ophthalmic artery is a branch from the internal carotid. And the vertebral artery unite to form the basilar artery. Again, the vertebral arteries unite to form the basilar artery. Follow me, which supply the brainstem and cerebellum. The basilar artery then divides into two posterior cerebral arteries. So now, the anterior and the middle cerebral arteries from the internal carotid, while the posterior cerebral artery from the basilar artery, which supplies the posterior 1/3 of the cerebral hemisphere. The circle of Willis, the very famous circle of Willis, is formed by anastomosis linking the carotid arterial system to vertebropatellar system. The anterior communicating arteries link the anterior cerebral arteries, and the posterior communicating arteries link the vertebropatellar system to the carotid system. This provides a collateral blood supply should one or more of the four extracranial arteries supply the brain become diseased. Just like the brain blood supply was important, the spinal cord blood supply is very important as well. The anterior spinal arteries arise from the vertebral arteries. Take care, the anterior spinal arteries arise from the vertebral arteries, not the carotid arteries, and unite below the foramen magnum to form a single artery. This single artery, which is not paired, is then supplied the pyometer and the anterior 2/3 of the spinal cord, including the anterior and lateral column, major motor tract. It anastomoses with the posterior artery over the conus medullaris. The posterior spinal arteries arise from the vertebral arteries, which pass down the spinal cord, but they don't unite. Again, the posterior spinal arteries arise from the vertebral arteries, which pass down the spinal cord, but they don't unite. But the anterior spinal arteries unite below the foramen magnum to form a single artery, while the posterior doesn't unite. They supply the posterior spinal arteries supply the posterior 1/3 of the spinal cord, including the major sensory tract, by the way. So the blood supplied by the anterior and posterior spinal cord is augmented by the collateral radical arteries. The radicular arteries, the most important being the branch of the posterior intercostal arteries at the site of the cervical and lumbar cord enlargement. Again, take care from this note. The blood supplied by the anterior and posterior spinal arteries is augmented by collateral radicular arteries, and the most important being the branches of the posterior intercostal arteries at the site of the cervical and lumbar cord enlargement. The artery of Adam Quist, which is a greater radicular artery, supplied blood to the anterior spinal artery and distal cord. It usually arises from the intercostal branch between T8 and T12. From those notes, just remember that the anterior spinal arteries unite below the foramen magnum, and the posterior spinal arteries doesn't unite, and the anterior and posterior spinal arteries both arise from the vertebral arteries. Take care. Dearest great surgeons, from the very important glands in our head and neck is the parotid gland, the major salivary gland. The salivary gland which having most of the benign tumors. So, most of the benign tumors will be in the parotid gland because other salivary gland will most probably be having a malignant tumor if they have a tumor. So, the gland is surrounded by a connective tissue capsule. In addition, the gland is enclosed in a dense fibrous capsule derived from the investing layer of the deep cervical fascia. This is the parotid gland. Again, the parotid gland is enclosed within a dense fibrous capsule derived from an investing layer of deep cervical fascia. And the applied anatomy of the clinical application of this important note that it's derived from the investing layer of the deep cervical fascia, it causes elevation of the ear lobule when there is a parotid enlargement due to the investing layer of cervical deep fascia. And the external carotid artery have left the carotid triangle and ascend and enter the substance of the parotid gland and open into the oral cavity opposite the upper circumpolar tooth. And the facial nerve emerges from the stylomastoid foramen and enters the gland. It passes forward superficial to the retromandibular vein, the external carotid artery, and divides into 5 terminal branches. It composed almost entirely of serial acini. This is the parotid gland. Again, the triangles of the neck are very important, and the posterior cervical triangle boundaries are anteriorly by the posterior border of the sternocleidomastoid and posteriorly by the anterior border of the trapezius muscle, and inferiorly will be the middle third of the clavicle. Those are the boundaries of the posterior cervical triangle, the posterior triangle. The arteries in the posterior triangle will be the third part of the subclavian artery, as well as the transverse cervical artery, as well as suprascapular artery and occipital artery. The nerves in the posterior triangle include the supraclavicular part of the brachial plexus along with the accessory nerve in the posterior triangle. The accessory spinal nerve is very important, and you have nothing to forget it because it's the blood supply of the sternocleidomastoid and the trapezius. So keep it in mind. So, along with the accessory spinal nerve in the posterior triangle, you will find the cervical plexus as well as the lesser occipital nerve, great auricular nerve, transverse cervical nerve, as well as supraclavicular nerve and the phrenic nerve. Those are very important and never to be missed. Did you notice that the phrenic nerve is within the posterior triangle? Don't forget it. Dear great surgeon, if you want to remember a specific artery in the head and neck, never forget the middle meningeal artery. And let's have the story of the middle meningeal artery from the beginning, because it is the main source of extradural hemorrhage at the terion, which is the weakest point of the skull. And the maxillary artery is a terminal branch of the external carotid, which is further divided into 5 branches, one of which will be the lucky middle meningeal artery. So, the middle meningeal artery and the maxillary artery are very important in our exam. The middle meningeal artery ascended through the foramen spinosum into the middle cranial fossa, and the surface markings are 3.5 cm behind and 1.5 cm above the zygomatico-frontal suture. Zygomatico-frontal suture. Again, the surface marking will be 3.5 cm behind, 1.5 cm above zygomatico-frontal suture. Keep it in mind. Take a wisdom from the maxillary artery. It's an important branch, and from its branch is the middle meningeal artery, which is responsible for the extradural hemorrhage. So, yet it's a very important branch from the external carotid and subdivided into three parts by a small muscle like the lateral trigoid muscle. The lateral trigoid muscle is not lateral and is not ignored. It causing opening of the mouth, and it will open your mouth to divide the maxillary artery into three portions. This little muscle, the lateral trigoid muscle, open the mouth to divide the great maxillary artery into three portions. So always keep this in mind. So the function of the lateral trigoid is to open our mouth. Lateral trigoid, yes, when you speak the name of the lateral trigoid, yes, you open your mouth, while the medial trigoid, you close your mouth. So the lateral trigoid opened our mouth to divide the maxillary artery into three parts. And here, the lateral trigoid divided the maxillary artery into, before the lateral trigoid, 5 branches, and lateral or within the lateral trigoid, 4 to 5 branches, and beyond after the lateral trigoid into 5 to 6 branches. Dear great surgeons, we have a master gland in our body. It's the pituitary gland. It's composed of an anterior lobe, which is the adenohypophysis, and the posterior lobe, which is the neurohypophysis. The adenohypophysis developed from the ectoderm, while the neurohypophysis developed from the neuroectodermal downgrowth from the floor of the third ventricle. The adeno from the ecto, the neuro from the neuro. The pituitary gland lies into the fossa of the sella turcica. Sella turcica is a Turkish chair in our skull, where the pituitary is situated. It's like a royal chair, Turkish royal chair. This is the sella turcica, which is formed by the body of the sphenoid bone, while the diaphragma sella bound the gland superiorly and the cavernous sinus laterally. And take care, the optic chiasm lies above and toward the back of the diaphragma sella. The pituitary tumor, rising upward, rests on the lower anterior part of the chiasm and the medial side of the optic nerve, resulting in hemianopia, and we will discuss this later in details when we cross and compress the optic chiasm from upside or downside, and we will understand it together. But keep it in mind like this. Another important gland is the fire gland, the metabolismic gland. It's the thyroid gland. The thyroid gland is fully developed at birth, and the development starts as early as the 4th week intrauterine life, and is fully complete by 6 weeks. The thyroid develops from the caudal end of the thyroglossal duct. The thyroglossal duct extends from the foramen cecum in the tongue to the neck. And by the way, this is another example of an overlapping question between the pediatrics and embryology, as well as the head and neck. The head and neck anatomy and surgery. We have a chapter called head and neck surgery, by the way. So, again, the thyroid develops from the caudal end of the thyroglossal duct, and the thyroglossal duct extends from the foramen cecum in the tongue to the neck. And the importance of the tongue, and I stressed on the tongue, due to the thyroglossal cyst, which develop from the epithelial remnant in the thyroglossal duct. The cyst usually appear in the first decade of life and is attached to the hyoid bone. Removal of the cyst necessitates removal of the body of the hyoid, and the lingual thyroid may be the only thyroid tissue, and hence the patient may be hypothyroid or euthyroid. By the way, it's very important to differentiate between the thyroglossal cyst and the goiter. The goiter will move up and down with deglutition, but will not move during protrusion of the tongue. And here is the differentiation between the goiter and thyroglossal cyst. Thyroglossal cyst will move up and down with deglutition, but will protrude with the protrusion of the tongue. It will move. Unlike the goiter, which will not move with protrusion of the tongue, because We know now the Thyroglossal cyst. It's a remnant. It developed from the epithelial remnant from the Thyroglossal duct, which is attached to the tongue during development. And by the way, the Thyroglossal fistula is almost always induced, iatrogenic, from the faulty removal of the Thyroglossal cyst. If we didn't remove the body of the hyoid and the whole tract with the cyst during the cyst trunk operation of the removal of the Thyroglossal cyst, this will induce an iatrogenic Thyroglossal fistula. And by the way, it's very hard to re-explore the neck. So please, don't be afraid to do it right. Remove the cyst, the tract, and the hyoid bone portion attached to this tract. Cyst trunk operation. Another important note regarding the thyroid gland, they are developed from the first and the second pharyngeal pouch, and the C cells are responsible for the secretion of the calcitonin, and the calcitonin is a tumor marker for the thyroid medullary carcinoma. The accessory nodule are well recognized in the base of the tongue. The thyroid may have an accessory nodule which are well recognized at the base of the tongue and usually weighs about 25 grams. The whole thyroid gland is weighing about normally 25 grams.